Oh, that was okay. I was like, what? Alright. Alright, first off, are all of these used to assess some part of circulation? Yes, they are. However, not all of them are done in the primary survey. Under circulation assessment in the primary survey, you do check a pulse. You do check the skin, color, temperature, and condition. And you do check for external bleeding, okay? You do not check the blood pressure in the primary survey. And you do not check cap refill time in the primary survey. These are vital signs that you can still check, but you do them in the secondary assessment. This is not info that I need in determining whether or not my patient's about to crash on me, okay? There's a question very similar to this on y'all's test, okay? And a common answer is the blood pressure. Don't check the blood pressure in the primary survey. You do check the blood pressure. I'm not saying don't check it, you just don't check it in the primary survey. You really want to know what is done in the primary survey and what's not. Still answering, Kenny?
Oh, okay, that's, sorry.
Okay. Alright, what's PPV?
Positive pressure ventilation.
Positive pressure ventilation, okay? In positive pressure ventilation, it is true that cardiac output is decreased due to increased intrathoracic pressure. It is also true that gastric insufflation is increased. And it is also true that hyperventilation and overexpansion of the lungs are possible. So these three things do happen as a result of positive pressure ventilation. Venous return to the heart is actually decreased in positive pressure ventilation. It's not increased, okay? Remember when we talked last time about our natural process for breathing? What was it called? It's the opposite of positive pressure ventilation. Negative pressure ventilation, okay? That negative pressure ventilation occurs by basically us sucking air in when we increase the size of the thoracic cavity. Part of that suction that occurs actually helps to pull some blood into the heart as well and increase venous return, okay? When we're doing positive pressure ventilation, you don't have that occurring. So in positive pressure ventilation, venous return to the heart is decreased. By the way, do y'all remember what that is called? Venous return to the heart. Remember there were like three things. It's preload. The pre-filling of the heart, or how much blood's going back in the heart, that's your preload. Your stroke volume is not increased. Your stroke volume could be decreased as a result of positive pressure ventilation. So that one's not going to be accurate. What is gastric insufflation? Gastric insufflation is increased during positive pressure ventilation. Matter of fact, you don't have hardly any of it at all during negative pressure ventilation.
We're seeing that.
That's just air you pushing your stomach.
Air going into the stomach, right? When I take a breath on my own, my body rightfully directs all of that air to my lungs. Okay, I'm not breathing in air to my stomach. My body knows where the air needs to go and it sends it to my lungs. When you take over the breathing for your patient, their body's not functioning appropriately, hence you're having to breathe more. And you have two openings, two pipes in the neck, right? With the trachea and the esophagus. It's just gonna split the difference. Some of the air is gonna go into the trachea, some of the air is gonna go into the esophagus. Well, when it goes into the esophagus, it starts to inflate the stomach like a balloon, and you get gastric insufflation. And you possibly, if you go too much, actually get your patient, they end up vomiting while you're ventilating them. And then we have a whole other slew of issues. But gastric insufflation is increased on positive pressure ventilation. Cardiac output is decreased because there's extra pressure in the chest, so the heart can't relax as well with that. And then hyperventilation and overexpansion of the lungs are possible side effects. How can you negate those side effects or decrease those side effects?
Doing the breaths over a second long.
I'm sorry, speak up.
When you deliver your ventilation breaths, you do it over a second long, you look just for the chest rise and fall.
And what's my rate?
One breath over every 6 seconds.
Every 6, not over 6 seconds, every 6 seconds.
Every 6
yes.
seconds.
You are far less likely to hyperventilate if you do one breath every 6 seconds, which is what the rate is. And literally just enough to see the chest rise. That does two things. It helps to reduce gastric insufflation, because once I see the chest rise and then the lungs are expanding, I don't need to keep pushing air in. But it also helps to prevent overexpansion of the lungs. Again, if you're breathing on your own, you take a breath, you actually have receptors within your lungs that tell the brain, hey, my lungs can't expand anymore, okay? They're too stretched, don't continue to force air into them. You're breathing for your patient, that's not working. You can actually pop a lung if you ventilate your patient more than chest rise. It's way more common in pediatric patients because their lungs are smaller. So it matters for all patients, by all means, like only enough to see the chest rise, but you're more likely to go to pediatric patients because we get anxious and we get zealous and we're pumping that bag up and we're not letting enough air out and we're trying to squeeze too much air into that pediatric lung. But all three of those are things that are true concerning positive pressure ventilation. I'm gonna tell y'all, it is not insert an OPA. I know when I wrote it up there, I originally wrote it wrong and I corrected it. I don't remember if y'all remember me correcting it, but it's not insert an OPA. Okay, that's not your answer there. Yep, suction the airway. Now, before I suction the airway, what do I probably need to do? A jaw thrust, right? Because that's not an option, so you go to the next best step, right? Jaw thrust, suction the airway, then what would I do?
Insert.
Say it again? Place an MPA or OPA and then BVM, okay? And all I'm trying to emphasize here is order matters. All of it probably needs to be done, but the order that you do the things matters. Why is this one not right? Like, we got it, we didn't pick it, but why is that not right?
Because the respirations are at 6.
Hmm?
They're inadequate breathing.
So you're still in the A on your ABCs, right? I need an airway open. first, before I can do anything about assessing the breathing. So we have the snoring, which we notice the snoring respiration, so we've gotta do something to make sure that airway's gonna stay open. So suctioning it, opening it, jaw thrust, all of that. Then, when I get to my breathing, rate and quality are part of the breathing assessment. And then we would probably determine, yeah, this patient needs to be ventilated. Oxygen's not gonna fix the problem. But here, you're getting ahead of yourself. I found an airway issue. I don't need to assess a breathing issue till I fix my airway issue. I know y'all haven't talked about medical emergencies yet. I think that's the next module we get into. However, I do believe in your book, it talks specifically about some signs, and it gives some signs, and that's the nature of this question. There we go. It is right upper quadrant pain and jaundice. Both are suggestive of liver disease. Remember, the liver lives in the right, okay, so that, hey, we might have an issue there. And then jaundice is just par for the course when it comes to liver disease. Mid-epigastric pain is not highly to be suggestive of it, simply because of where the liver is located. You might have some referred pain there, maybe, but it's not uncommon. Not the left side, our liver's on the right side. And melena has to do with blood either in the vomit or the stool. I don't remember which one. Do y'all know? I have to Google it. It's one of the two. You have blood in either vomit or the stool. I think it's in the stool, because I think hematochezia is in vomit. Either way, it's not from liver disease. This question, it's not necessarily asking you about liver disease. Again, I know you all got medical. But there are some questions related to, like, when you're assessing the quadrants, knowing what organs are in the quadrants, these are the types of issues I might have. Or, you know, when you're assessing the skin color, you know, is your patient pale, or are they cyanotic, are they jaundiced, and what they're suggestive of. So that's where the nature of this question comes from. Not do you know the signs of a liver disease, because y'all aren't there yet. It is the chief complaint. You get this, why did you call 911 today? Because my chest hurts, or my toe fell off, or whatever the case may be. The chief complaint is not always necessarily the thing that you're treating. I don't know if I gave it to y'all or another class, but I once had a patient call 911 because they were having chest pain. So we're thinking medical. What they failed to tell us is they had a 3-inch pocket knife sticking out of their chest. So we had a trauma patient, okay? Chief complaint was chest pain. That's why he said he called us, okay? I was actually treating, they called over some french fries at McDonald's. It was really stupid. But that's why his chest hurt. provocation or palliation?
Provocation.
Provocation, yep. What is this answering?
Onset.
Onset.
Onset, yep. This one,
Radiation.
radiation, and this one,
Fall.
which one?
Fall.
Actually, this would be severity, yeah. And then, time. Yep. You do have to calculate a GCS on the test. Now, it gives you answer choices, but you will have to calculate a GCS on the test. Mary, Haley, Haley. Good. 12. It is 12. All right. What is the smallest GCS your patient can have? A 3. You cannot have less than a 3, okay? Abraham Lincoln, who is dead and in the grave, has a GCS of 3. So if you tell me you have a GCS of 0, I'm going to look at you sideways, all right? Cannot have less than a 3. That is the bottom number on all of these, all right? And the next best thing is to memorize the top number, okay? Always remember it's 4, 5, 6, but another way to remember it, this is eyes, okay? You need 2 eyes to see, and if you wear glasses, you need another 2 eyes to see, for a total of 4, right? This is verbal. I've never heard them, but somebody told me this, but before Michael Jackson got his start, he was Michael Jackson 5.
That's also the Roman numeral for 5.
There you go. It is the Roman numeral 5, so there's another way, okay? And I know nothing about vehicles, but I think a 6-cylinder motor is good. Is that right? Wrong? No? Is there 6 cylinders in a motor? Okay. Someone told me that one time. I'll explain to the heart to you all day long. Ask me nothing about a car. All right, so these are your maxes for these. The minimum for each is 1. The max for each is up here, okay? You can get those. The rest we're just filling in. Now, the eyes are easiest because it goes along with AVPU, okay? Remember AVPU, alert, verbal, painful, unresponsive? If they're alert, it's 4. If they respond to your voice, it's 3. If they respond to painful stimuli, it's 2. And if they're unresponsive, it's 1. Eyes are the easiest to remember. Okay, from there, with verbal, they get a 5 if they are answering questions appropriately, right? They get a 4 if they're just somewhat confused, all right? Then you have 3, which one of them is hold on, I gotta think of what my stuff is. 4 is they're somewhat confused. One of them's incomprehensible sounds, and one of them is they're made.
It's like
Two is the
provocative.
sound.
Yeah, two would be the sounds. 3 is if they're answering the question, but it doesn't make sense in
words,
response.
yeah.
So like if I said, what's your name? You say cat, right? That would be 3. Here, this one, they get a 5, they get a 6 if they obey commands. They get a 5 if they withdraw, or if they localize the pain. They get a 4 if they withdraw from pain. They get a 3 for decorticate posturing, and they get a 2 for deceribate posturing, okay? Again, this is AVPU. This is a verbal response. This one's a little bit harder to assess. So if I tell you to raise your hand, you raise your hand, you're following commands, you get a 6, right? What is the difference between 5 is localizing to pain and 4 is withdrawing from pain? What would be the difference in the two? Or how would you tell the difference?
That hurts. And
I
then
thought she
them,
said
like,
pulling
pulling
away.
away.
One of them, if you localize the pain, you typically use cross-body resources to identify it. Basically what I mean, if I go to start an IV on a patient and they take their arm across their body, they stop doing that, they're localizing to the area, okay? They've identified the source of the pain. It is right there where you're trying to start the IV. Versus withdrawal from pain, hey, I know there's something wrong and it hurts, but they're not necessarily identifying where the pain's at, okay? Which is why they get score higher if they can identify the source of the pain. Okay, so obeying commands, localizing to pain, withdrawing from pain. This is decorticate and this is deceribate posturing, okay? Decorticate posturing, everything is pointing to the core of the body. So their toes are either pointing out or inward, and their hands and their fists are like this, okay? Everything's pointing towards the core of the body. In deceribate posturing, their toes are either pointing out or outward, and their hands are either like this, or like this, or like this, or something where it's going out or away from the body, okay? So decorticate is coming in. I always say deceribate looks like they're celebrating. They're going out. Why do they score higher on decorticate posturing versus deceribate?
They can pull it in.
Think about what happens when you're trying to, when you're in a state of shock. All your blood shunts to the core of the body, right? Everything's coming out. I'm trying to preserve everything that's vital for me to live. I don't need my hands and feet to live. I need everything that's in here. So it comes to the core. By the time they get to deceribate posturing, the body's like, yeah, I'm not even gonna try anymore. Okay, so they're now at deceribate posturing. This, they're doing absolutely nothing, okay? So you do want to know this. There is at least one question where you're calculating GCS, although it's a multiple choice question. You're not writing in the number, so you should get close, okay? Any questions on that?
I do have to leave though if you want to kick me out of there.
Okay, Brett,
Yeah.
I will post this in the thing. Also, there's one next week for your following exam.
Okay.
Yeah.
All right. Thank you.
That question, I don't mind.
Say it again. Are you still answering here? Are you still answering?
It's still on the last question.
Can you refresh it? Maybe the next one will pick up. Alright, yes, it is beginning CPR. Y'all, I cannot figure out why this question gets more people than anybody I've ever seen. It does the same thing in BLS when you take the BLS class, okay? If your patient is unconscious as a result of choking, you start CPR, okay? If they're conscious and choking, then you can do your back slaps or abdominal thrusts or whatever. They go unresponsive as a result of choking, you start CPR. The number of people that miss that question astounds me. Like every year, people miss this question, okay? But you want, and you gotta pay attention to that word. I think that's the word that gets them.
Okay.
They're unconscious from choking, then you start CPR. Who do you do back slaps on?
Baby.
Babies if they're conscious and choking, right? Let's say the A patient, yeah, the A, I don't know why I did that. Identify the patient signs. Are you seeing the question, Mary? Like it's on it? Okay. There we go, good. All right, I can point to cyanosis, I can see bluing around the lips or on the nail beds or whatever. I cannot tell you that you have a headache. There's nothing about you that I can look at you and say you have a headache. You can tell me you have a headache, in which case you're complaining of a symptom, but I can't tell you that you're in pain. Same thing with abdominal pain. I can't tell you that you're hurting. You can tell me you're hurting. Now, I can see that you're guarding your abdomen, so I can suspect that you have abdominal pain, right? That is something I can point to. But generally, pain is a symptom, it's not a sign. You can't point to the fact that they're in pain or identify the fact that they're in pain. Tachycardia is also something that you can see or point to. You can assess their heart rate. Matter of fact, tachycardia is something that you would get in your vital signs. So it's like right there in the name.
Yeah, I think in the book it says it can be like observed or measured.
Yeah, observed or measured is a sign. A symptom is more subjective. Double check me on this one in your book. I'm pretty sure I know what the number is, but I think this one is like a book specific one. Yep, 500. $500 is what I have. If your book says something different, let me know, but I'm pretty sure 500 is the answer there.
Technically, it says most EMS services, say anything 500 to 1,000 or whatever is not enough to put in, but whenever we were going to class, she said it was 500.
Yeah.
So 500.
500 PSI, yeah. go. Alright, I'm looking, what's the mnemonic that we use for this? You remember?
Pearl.
Pearl. Pupils are equal, round, and reactive to light. Equality, I should see pupils that are the same size. If they're not the same size, we have an issue. Some people have a congenital, I won't call it defect, a congenital trait in which their pupils are the same size. So if nothing else seems to be off with your patient, ask them, do you have different size pupils normally? But if they're not equal, it could be a sign of like a stroke or a head injury or something like that. Reactivity, do they get bigger or do they get smaller when you shine lights on them, or get bigger in the absence of light? And the shape, they should be round, okay? We do not assess for the color in the pupillary reaction. They should all be the same color. I've never heard of pupil not being black, okay? The pupil is the black part, the color is the part that's around it. The pupil is equal, round, and reactive to light. You can tell me, you ain't gotta look for look at you. Alright. A pertinent negative. Yes, that's a sign or a symptom that you would expect to be there, but isn't. For example, if you have a diabetic patient and they are confused and altered, okay, and you're like, oh, well, this might be a hypoglycemic case, and you check their sugar and their sugar's 128, okay? It's a pertinent negative for hypoglycemia. Sugar's not the issue. We have a finding that contradicts that. Another example, you have a patient who has chest pain. They're complaining of chest pain. You ask them if they have any difficulty breathing and they say no. That would be a pertinent negative, okay? So it's a symptom that's or sign that you would expect to be there that's not there for whatever reason. Either that's not the issue or this particular patient doesn't have that. They are important because they help you with your differential diagnoses. What is a differential diagnosis? Differential diagnosis is everything that you think could be wrong with the patient, and you're working to narrow it down to your field impression. So for example, we use the altered mental status, right? My patient could be altered because they're having a stroke, they could be altered because they're hypoxic, and they could be altered because their sugar is low. All three of those are a differential. Now, I check their sugar's fine. I could probably eliminate that one. I check their oxygen level, and their oxygen level's fine, so I eliminate that one. I do a Cincinnati stroke scale assessment and they're positive on that. I now have my field impression, but I started with a few different possible things that could be causing my patient's condition, okay? Every patient, you should be working from a list of differentials. You should not hone in on one thing and only look for things that confirm or deny that. You need to, okay, with these symptoms, what's everything I can think of that could be causing these symptoms? And then specifically work to eliminate or include whatever that is that is going on with your patient. send Mary?
You put the, thing, my phone just did something, it's just completely took me out, I need the code.
It's up here.
Data scan.
It's up there in the corner, but we only have 4 questions left.
Okay.
Alright, so, you have 2 types of pressure that you get in a blood pressure. You have the systolic pressure and the diastolic pressure. The systolic pressure is the top number and it's when the heart is squeezed. The diastolic pressure is the bottom number and it's when the heart is relaxed. So with every heartbeat, you have systolic, diastolic, okay? The pressure that is in the ventricle when it is relaxed is your diastolic pressure, okay? A high diastolic pressure is not good because it's when the heart is supposed to be relaxed and it's pressurized when it's relaxing. Neither is good, but we'll pay a little bit more attention to a higher diastolic than we will a higher systolic. Alright, this, have y'all covered specifically shock yet, like the shock chapter? Okay, this you should cover in the shock chapter, and this is just a term I made up. There are 2 on here. There are 2 times that you do a CAB assessment. So most of the time when you're doing your primary survey, it's ABCs, right? The 2 times that you do CAB is if when you are approaching the patient, they have like 0 signs of life. They're not moving, there's no, you can't see chest rise, you're calling their name, they're not calling, you have no indication that the person you are approaching is alive. Check a pulse when you get to them, okay? That would be the C of CABs. The other one is when they have bright red blood spurting out of them, okay? Not dark red oozing blood. If I'm walking up to this person and there is blood literally spurting out of this patient, they have an arterial bleed, which means in 2.5 minutes they could be dead. You're not gonna have a chance to do anything with the airway or breathing because there's no blood left in their body, okay? You have to control that bleeding. That's considered a life threat, okay? So you would then do your C before you did your A and B. Those are the only 2 times. No obvious signs of life. You need to check a pulse when you get to them, or there's obvious bright red blood that's coming from the patient. You can see it when you're approaching them, okay? All of the others, you would still do your ABC assessment. Is the airway open? Are they breathing? You know, what's the circulation like?
If you have a rigor mortis, you wouldn't really do anything.
Yeah,
I mean,
you're dead. Sorry, I'm not gonna do that. And that one though is more state dependent. Like in the state of Mississippi, you do not need any medical license or anything to pronounce anyone. When I worked in Alabama, their head could be here and their body could be over there, and I still had to call the doctor to pronounce them. I mean, that's a state specific thing. Made no sense. I'm like, I promise you, they're not alive with their body in 2 different spots, but. Yes. Why is this one not right?
Because it's 60 to 100.
60 to 100, this one's too high, okay? What should the BG be? Yes, but what should the number be?
120?
I think it's 65 to 120, there's a range for it. Is it 120? I'm pretty sure it's 120. It's changed a few times over the last year, but I'm pretty sure it's 120. 65 to 120 in a fasting state. Okay, if they've eaten something, it would be higher, but that is too high. Is this high or low?
Low.
It's low. What's your normal?
120 over 80.
120 over 80. And really, that's like the higher end of normal. Anything less than 120 systolic is good, and less than 80 diastolic is good, but 120 over 80 is considered normal. Anybody in here a history buff? What strange ingredient was used in the mortar to build the Great Wall of China? Never mind. Oh, never mind. Sticky rice, apparently. Trivia Friday on the radio station my husband listens to. He always takes me a trivia question. Sticky rice.
Interesting.
I would not have known that. All right. What is a pulse oximeter used to assess?
Oxygenation bound to hemoglobin.
Yeah, oxygen. And actually, technically, it's not even oxygen. It is used to assess
How much is bound?
something bound to the
Yes.
hemoglobin. Because what will bind to hemoglobin better than oxygen?
Carbon monoxide.
Carbon monoxide, yes. So percentage of something bound to the hemoglobin, not necessarily oxygen, although most of the time it's oxygen. All right, why is this one wrong?
Because it doesn't get that
Because
average.
It's not an average, yeah. And it's not in,
It's the map.
it's not Venus, it's arterial, okay? But it's also not an average, it's a point in time.
MAP, the map, or whatever is the average.
Map would be the average, yeah. And then we know what a glucometer is used for. Capnography is used to assess the amount of CO2 in exhaled air. You can use, it basically looks like a nasal cannula, but it has a little lip device on it. So in a conscious patient, instead of just putting them on a nasal cannula, put them on that device. It hooks up to a monitor. Y'all don't have to read it, it's an ALS scale of reading it, but it's an ALS provider that will read it, interpret it, do something with it, but it's telling the amount of CO2 that's coming out. What would be normal? Y'all know the range for that?
35 to 45.
35 to 45, yep. All right, last one. Do what?
I don't remember ever seeing that. Sounds right.
All right, first off, where are the orbitals at?
Eyes.
Right here, so it probably has something to do with the eyes. Bruising around the orbitals is raccoon eyes. Where's battle signs at?
Behind here.
Behind the ear, yep. What's anisocoria?
Pupil
Yeah,
typically,
their pupils are different sizes. One's dilated and one's pinpoint. And what is Kerr sign? Kerr sign is actually one I mentioned earlier, I didn't call it by name, but it's when there's referred pain to the shoulder from a spleen injury. They get hit in the left side and that rib cage lacerates the spleen. They share a nerve pathway with the shoulder, so the patient may actually be complaining of shoulder pain. It is their spleen that's injured. That specifically is called Carey sign. All right. We made first place. Good job. There is one of these next week for exam 3. I don't remember, I know Jackson County class, your test is only gonna be on Thursday. I don't remember when y'all are testing Harrison County, but I know next week is the Friday before, so it's either Monday or the Wednesday. I will post the paper version of this on, Canvas, and I'll do it today. I know I forgot to do it last time, I did not mean to do that, but I'll make sure it gets posted today, the paper version.